Welcome back to the Oncology AI Lab. I'm Dr. Alan Lee, a community hematologist oncologist. Now, in this encounter of the AI stress test, we'll be using the same case that we did in the first video, but with a different prompt. So the question for today's stress test, with a better prompt, do we get a better answer? Or are there still errors out there? Let's find out. So here we see the exact same prompt that we presented to the AI last time. 72-year-old, stage 4 colon cancer, and innumerable liver lesions and lung lesions, so not resectable. And then of course the HER2 positive on a molecular test with other markers being wild type. Now the prompt differed this time with a few specific changes. First, we asked the AI before answering, look up the latest FDA approvals, the guidelines, and also relevant publications that could be practice changing. In doing so, we're forcing the general purpose AI to do a search before formulating its answer. So it's going beyond the trained data, which has a cutoff date. And in doing so, I'm hoping that it can surface newer data and giving us a more up-to-date answer. And then of course, the same thing as before, listing the decision nodes and confidence level. All right, so as you can see, it did a search first before formulating the answer and performed search based on the questions that we're asking and based on its own research from the looks of it. All right, so give a correct summary that it's stage 4 disease, which we mentioned. And similar to last time, the HER2 status got its attention first, which rightfully so, telling us that it's paying attention to this as a molecular marker. It also correctly stated that there is a difference between how HER2 positivity is determined, especially when it comes to eligibility for trastuzumab deruxtecan. Cited with high confidence level here. And multidisciplinary resectability assessment. The fact that we mentioned that it has innumerable liver lesions, this makes it quite a bit less likely, but certainly tumor board presentation is always a consideration. All right, so note 3, I think this is kind of what we want to see if it gets right. So the first line systemic therapy, it correctly identified that the HER2 amplification is likely a resistance mechanism for anti-EGFR therapies like cetuximab and panitumumab. So it's good that it's highlighting it here. And it got the right recommendation, at least based on today's standard, FOLFOX plus Bev, so the typical chemo backbone together with bevacizumab. And of course, the purpose for the stress test is more to see where the AI can operate within the confine of clinical reasoning and current standards, as opposed to what should the right HER2 directed therapy be in colon cancer on a broader level. All right, so here the next decision node, it asks whether the HER2 directed therapy should be added in the first line, which is the exact mistake that it made last time. And it correctly identified that there should not be HER2-directed therapy in the first line, at least based on today's standard, for patients who are able to take the intensive therapy. So here it mentioned the justification based on the current approvals. And it cited the Mountaineer 3 trial as an ongoing trial that's studying this specifically. So it's holding its recommendation for the FOLFOX plus Bev, which I think is quite reasonable. All right, and decision note 5, so it's interesting here, is talking about the sequencing of the treatment after chemotherapy progression, which certainly is something that we think about and it's a highly debated topic. What would be the best second-line treatment for stage 4 colon cancer disease that are HER2 positive? It listed the option A and option B first. So tucatinib plus trastuzumab, which is based on the Mountaineer study. And of course, it correctly highlighted that it has the accelerated approval from some time ago. And option B would be trastuzumab deruxtecan or Enhertu. And it correctly highlighted here that A is really more for individual who are identified HER2 positive based on IHC 3+. So the overall response rate of 61.3%, that seems to be a lot higher than what I recall. So we'll have to check the source now. And it cited OncLive, which is the Oncology news report site. Let's take a look. So the article is reporting on the accelerated approval of trastuzumab deruxtecan back in 2024. And let's see if we can find that 61.3%. So it mentioned here the few landmark trial for the trastuzumab deruxtecan. Of course, the Destiny CRC02 here would be the most relative one. So here actually listed the overall response rate was 46.9%, so different than the 61.3 that it's pointing out. Let's see what's going on here. So here it actually listed for HER2 expression of IHC3+, the overall response rate is 61.3%, which is what's quoted in the response. However, this is for Destiny Pan-Tumor02, which is different trial than the Destiny CRC02. Pan-Tumor02 includes a few different cancer types. However, individuals who were enrolled in this trial with breast cancer and colon cancer, they were actually excluded since HER2 has different indication for those disease already. So the citation here of the overall response rate of 61.3% is actually inappropriate since it's being quoted from a different study that does not include any colon cancer patient. So here, despite asking it to perform a search first, and even with a nice citation here, the interpretation of the source is not quite accurate here. So this should certainly be flagged. It's lower than the 61.3%. And here it also talked about the sequencing of HER2-directed therapy as the next point, which certainly is a hotly debated topic. For individuals who are IHC3+ or just HER2 positive, what would be the best second and third line treatment? So here actually cited that the fact that in HER2 has a striking response data, which unfortunately is based on the wrong citation here. So we have to be really careful here now. Based on the response rate, is recommending trastuzumab deruxtecan first and sequencing the Mountaineer regimen to be later. Even though this mentioned vice versa is reasonable too. And here I made the recommendation to proceed with trastuzumab deruxtecan after progression on chemo and with tucatinib trastuzumab as the subsequent line therapy. So notice here, there is no data that's available, at least at the date of filming, to tell us what's the best way to sequence the HER2-directed therapy. The fact that this is being presented here, it really should be marked that this is an opinion and not based off existing data. And the fact that the AI is presenting facts and opinions similarly, that's something that the clinicians really need to be aware of. We won't quite catch it not knowing there are no head-to-head data, at least in this particular space. And moving on, the decision notes here, it's mentioned checkpoint inhibitors are contraindicated based on the PMR status, which is correct. And it talked about the germline testing with the tumor board. And here it's giving the summary. Certainly overall a dramatic improvement compared to the last session. The fact that it was able to correctly cite the right treatment recommendation for this particular case based on today's standard. And it also mentioned the subsequent line therapy. However, the AI still crossed the tumor type similar to what it did before, but just not as glaringly. Before, extrapolated the HER2 evidence from breast cancer, and this time extrapolate evidence from the Destiny Pan-Tumor02 to the colon cancer case. So as you guys can see here, prompting the AI to search first, it gave a dramatically better answer. It was able to go beyond its trained data, and it no longer just reliant on pattern matching, pattern completion, which I suspect what's caused the error in the last encounter. However, what a better prompt did not fix, as you guys saw, was that the tendency for the AI to over-extrapolate, and in this case across tumor types, still exists, but just a lot more subtle. Instead of the extrapolation of the treatment itself, it was within the efficacy data, which arguably makes it a lot harder to spot if we didn't quite know the response rate range for second-line colon cancer treatment, we would not have spotted that. Similarly, because the overall output is much better, the second error, which is AI presenting its quote-unquote sequencing opinion in a way that they would as any other fact, and the fact that it's sandwiched between guidelines and other citations makes it harder to spot too. At tumor boards or in conferences, there would be typically a lot more caveat before giving those sequencing recommendations. Both of those failures require clinical knowledge to catch. It's not obvious in the formatting and certainly not flagged by the AI. Now, a quick word on retrieval augmented generation AIs or RAGs, like OpenEvidence. The architecture of those purpose-built AIs forces a search automatically before answering. And it sounded like the solution to the problem that we're documenting today. However, the RAG models has their own failure modes too. It can struggle to distinguish guideline recommendations versus primary data, and it can weigh the trial data and the guideline differently, especially when the guideline lags behind recent approvals or recent trials. And we go deeper on those on the Substack if you're interested. So coming back to the case, the lesson from this and last encounter still holds. Prompting is a clinical skill. The 3 lines of anchoring these AI's reasoning to approvals, guidelines, and literature, it really changed the output in a more usable way. However, as you can see, that does not resolve all the errors. Some of the failure modes that we documented are still there, but it just becomes even harder to spot. So prompting better, then audit what comes back. Both of those are clinical skills in the age of the AI, and they're not the same. We'll see you on the next one.